Well, good morning, and thank you very much for asking me here today. I know Dee has a stop clock here, so she's got it running already, so I better get on with it and not hold you up. So it really is a pleasure to be here today with you. I just thought two things I wanted to convey. First of all, the kind of global picture and the epidemiology, and I'm grateful to my colleagues in Public Health England for working with the NHS on a real partnership, actually, to get under this, to meet the goal of eliminating this for everyone. It's a most unusual situation in public health where we can actually say we can eliminate something. Usually we're living with it for many, many years. So this is a key moment. The second thing is how things are working, what exactly is going to happen. So let me try and get that in 10 minutes. First of all, quick thing to say, I always start with we are in a place called London. It means things to people. Other countries fit into it. It is that big. It is vast. And nevertheless, there are people here who we keep meeting who work to make London better. And part of them are sitting here, and I meet other groups, and I keep meeting them because there are people who really care. And in an era when it looks like nobody cares about anybody, particularly the most vulnerable, I just want to reassure you that isn't my experience. And I'm not talking about politics here. I'm talking about clinicians, particularly community activists, members, people who are working for a better place. And it has its challenges. And hepatitis C, certainly a third of the prevalence of hepatitis C in people is in London, so we certainly have an issue there we need to address. The Mayor we mentioned. So the Mayor this year put through a health inequality strategy through the London Assembly that was accepted. It's very broad brushed. The hepatitis C is in there, but it's not a topic based. It's not individual disease based as such. It's about particularly people who are vulnerable, who the rest of us can look after ourselves, but actually they need more support. And that's what Inequalities is about. It's proportionate. And there are 5 areas in there: children, mental health, communities, the environment that we live in, and that is often worse in places that are most vulnerable, and then healthy lives. And in there is a wealth of detail and commitment and resource to make things better. And that is on the website, and that's what I'm working for with the Mayor. And we will be held to account by the London Assembly to show progress on that. We do have indicators and so on. So there is accountability in this. Moving on, just to let you know, in the Mayor's world, there are 7 strategies. I'll leave these slides with you, but the idea here is to get health into all of them. So transport, the environment, the arts and culture, the business sector. I want people to think about our health as a city as well as the work they do. And in that way, we can reach many more people, particularly those who are more vulnerable. So we're thinking health in everything we do. We also have a partnership in the way you have a partnership. We have a big London partnership that works together on prevention, and we learn from other cities. So we can talk about that later if you want. Now on to hepatitis C itself. So this is the global burden of disease. You don't need to see the detail here. You can see how the lighter colours, the dark blue is where it is either unknown or there doesn't seem to be a major problem at the moment. The lighter blues getting into orange and red, there are very significant problems with hepatitis C. And this measure here is mortality and the burden of disease from mortality from cirrhosis and hepatitis C globally. And that will show you some of the reason why perhaps we focus the way we do on particular ethnic groups. But it's not a world that's free of hepatitis C by a long shot. This is a nice infographic, but really there's too much detail in it. But it's just telling us really the different components of how we want to address this condition now. And the key issue for me is the new developments in that, the service changes. And I know others like Graham will talk about this in some detail, but that's it in summary. So the London, I have to look because this isn't coming up. Oh, it's down here. Right. So the London picture here. So just to say that as we've said, 70% of those who we now need to address with these new treatments, this particular new treatment, have had a history of injecting drugs. So some won't even know that they have hepatitis C, and that's one of our challenges, is about a third of the people who may have it wouldn't know that. And so we're now getting to a stage where we're trying to find people who may not be aware. But on the other hand, we have worked together with the NHS on estimating who and where and how we need to do this. And 2/3 of the people who inject drugs, as they say, in London had hepatitis C infection in 2016, and a third were unaware. I think you can probably read the rest of that, so let's move on a little bit. That's the kind of London picture we're looking at the moment. A couple of prevalence and sort of epidemiology sides. So these are the operational delivery networks, and there are, of which there are 4 in London, but there are many in the country, and we now have all the networks' data. I know before you all say it, the data are probably not quite right yet, but that's the point of a stakeholder and a partnership, is that you work together to get it right. But we've got to start somewhere. And the South London network appears to have some of the greatest numbers at the moment, but many of the good news are, many of those are ex-people who inject drugs. The dark blue are people who currently do. And then the yellows and the others are South Asians and other groups. So you can see where all this is about is really where the risk may lie. And this, I will leave it with you, but it just gives you a sense of the proportion of clients in drug treatment services who received a test. And this is critical. The drug treatment services are critical to getting this right. So when people are accepting those treatments and rehabilitation, they get a test, they also get needle exchange and other things that prevent the transmission. But the testing is critical because that's the key to unlocking how to get towards the treatment. And you'll be aware, and I'm sure others will say, that the ambition here is to get 90% of people who are who have hepatitis C tested, and 80% of those on effective treatment, of which there is, of course, effective treatment now, and the NHS has ensured that will become available. I've seen this with other conditions where we set these kind of ambitions and we're meeting them. So these things are good ideas, actually. They do motivate, particularly those in the service, to keep going. Right, and here we have a hospital admission across the boroughs of London. So these are all borough data. They're very useful. They may not be completely right, but they're very useful just to see currently where we think the risks are. And we've got in the middle here, so the green is England. Sorry about this. I'm a bit blind myself, and the buff is London. So some places have much higher levels of admission, and some of those are central London. It's where you'd expect. Others, perhaps, on the outer rim of London, less so. So hospital admission, we would hope that will go down as more people get effective treatment. Predominantly male, looking at ethnic minorities here, particularly South Asian ethnic minorities and those who've had tests and so on. Now, I just wanted to, before I'm told to get off the stage, just focus on some of the things you might expect to talk about. So obviously awareness is a big issue. And part of that awareness mitigation is the re-engagement exercise, which is the 4th point there. This is a big, big deal. There's now a hepatitis C register. There's now a system in place, and I like to know how things work. So there is a system in place that has identified patient-identifiable information with the aim of finding the people who could benefit. This will work through clinical pathways, it'll work through general practice, it's cooperating with the labs so that we know what we're doing, and we're making big efforts to try and find people. Prisons are important because the prevalence is 14 times higher in prisons, and the opt-out, we found, has worked in other systems, and we really do want to address hepatitis C in prisons. So there are real efforts here to get to the populations who need it, and these are not hard to reach. We need to reach them. And then there are supporting documents that both the Hepatitis C Trust has produced, which are stunning. I've been through them and they really are attractive. They're also very practical, but also Public Health England itself has produced some good information on its website about this. So this is all about ratcheting up awareness. And as the report from ourselves say, there is much more to do. So it's very pleasing that we're getting under this, but we've many, many more months and years to go. And we're ambitious. We want to do it by 2025. So that's where we will be. And I'll leave you with this wonderful material. So good luck. We'll be alongside you. And thank you very much.